including head and neck. So we'll be discussing only head and neck, that is ENT based. So HIV is retrovirus, viral RNA into DNA. So this is the picture showing the virus. This is the virus picture. So there are two types of HIV, type 1 and type 2. Type 1 is more common and more pathogenic, and type 2 is less common and less pathogenic. So once it enters the host, this attacks the T lymphocytes and other CD4 surface markers. So with fall of the CD4 lymphocyte, that is, if it is less than 500 cells per cubic millimeter, the immunodeficiency is seen and many other opportunistic and malignancy can appear. So that means in HIV, the CD4 count gives us some clue. So CD4 count is a very important investigation what you should do for HIV. So when the CD4 count cell appears less than 200, then death may appear in about 2 to 3 days. So when the CD4 count is less than 500 cells per cubic millimeter, then it is essentially symptomatic. If it is in between 200 to 500, then early manifestation of HIV is seen. So when the CD4 counts are less than 200, then it is vulnerable to process associated with AIDS. And if the cells are very less, then it is high risk and they may have opportunistic infections. So about the epidemiology, first case was detected in 1980, and these cases were detected by prospective analysis to have occurred in 1978 in USA and late in 1970 in Equatorial Africa. The first case was registered in 1986. That is in India we are talking about. So in India, 2.1 million people living with HIV, 0.3% adult HIV prevalence, 86,000 are new HIV infections. This is the current scenario, what we are talking about. 68,000 is AIDS-related deaths, and around 43% is on antiviral treatment. So how it is spreaded? So this is the picture showing the spread of HIV. So it is spreaded through sexual contact, pregnancy, childbirth, breastfeeding, injection, drug use, occupational exposure, blood transfusion, and organ transplant. So this is more related with health workers. Mind well. So we have to take care, the health workers especially. The risk factors, what we see are, that is, homosexuals, heterosexuals, prostitutes, truck drivers, in IV drug users, recipient of blood and its products, hemophilia, thalassemia, dialysis. So in these cases, what we do is we do a blood transfusion. So that may be one of the cause. Children born to HIV mothers. So hazard to health workers is from blood and the blood fluids such as amniotic, pleura, peritoneal fluid or pericardial fluid. The risk of acquiring infections from specimen of urine, sputum, stool, tears, sweat and vomitus is negligible. So all the HIV patients will have head and neck manifestations during the course of AIDS, and they are ear manifestations, nose and sinuses, nasopharynx, oral cavity, neck. So in neck, HIV lymphadenopathy is seen, infections are seen, neoplastic and even submandibular and parotid lesions are seen in this patients. So that means whole of the head and neck is involved in HIV. So the ear manifestations, what see here, I have not written the investigations and the signs and symptoms, because once you know that the external ear is involved, so you can write all the external otitis when they are maybe a seborrheic dermatitis or any infections in the external ear can lead to all the signs and symptoms which we usually routinely see. So that if you want to add, you can add in this answer. So in external ear, Kaposis sarcoma of pinna, seborrheic dermatitis due to secondary infections, oral polyps due to pneumocystis carinii, and malignant otitis externa. So these are the infections what we see in the external ear. In middle ear, what we see is serous otitis media due to adenoid hypertrophy. Pathogens involved are Streptococcus, Pseudomonas, and Pneumocystis carinii. So in this, what happens is if the middle ear and if the ear infection is seen, usually it causes sensorineural hearing loss due to cytomegalovirus affecting the inner ear or CN, that is cranial nerve, 8th cranial nerve. So this is very important. That means it may be associated with herpes simplex virus also. So causes of SNHL in AIDS. So what are the causes? Opportunistic infections, ototoxic medicines, neurotrophic effect of HIV. So even you can see facial nerve palsy, that is Ramsayan syndrome, or herpes zoster corticus, that is seen in 16% of AIDS patients. Reactivation of latent varicella zoster virus is seen. So the clinical features what we see in this are vesicles of the ear and facial nerve palsy, ear pain, tinnitus, vertigo, and SN loss. So these are the things what you see in facial palsy associated with HIV. So in nose and paranasal sinuses, what we see is herpetic lesions of nose. So it may be acute, it may be associated with acute and chronic sinusitis. Fungal sinusitis is very common. Burkitt lymphoma is very common. So the pathogens, unusually pathogens seen are Ligonia, Alternaria, Cryptococcus, Candida, and Acanthoaledra. So the fungal sinusitis which are caused are Aspergillus, mucormycosis, which are rapidly invasive and extends intracranial. So this is very important about fungal sinusitis, which is associated with HIV. So the treatment is, so when you write, please write all the signs and symptoms, investigations of sinusitis. Okay. So now the treatment is antibiotics, long course of guaifenesin and topical steroids. Surgical treatment is done. For fungal sinusitis is FES, that is functional endoscopic sinus surgery, what we do routinely. So nasopharynx manifestation. So what are the nasopharynx? In this, remember well, they have HIV patients is always associated with adenoid hypertrophy. So all this patient who comes with HIV should be investigated for adenoid hypertrophy. Kaposis sarcoma and non-Hodgkin lymphoma can also involve nasopharynx. Serous otitis media, serous and acute otitis media can occur due to adenoid hypertrophy. So please do write. I have not added all this, the signs and symptoms and investigation of each this thing, because it is almost same. It has been discussed by all the three faculties. So you should write all that findings. So introduction about what is the oral cavity, and so we have finished now here. and nose. Now, in oral cavity and oropharynx, what are the manifestations? So, in oral cavity, the oral candidiasis and hairy leukoplakia is highly suggestive of HIV infection. That means when a patient comes with oral candidiasis, then you must, with diabetes mellitus, you must investigate for HIV infection. Kaposis sarcoma lesion may ulcerate and become secondarily infected. Herpes simplex stomatitis, acute necrotizing ulcerative gingivitis and necrotizing stomatitis, gingivitis and peri-odontitis, Herpes ulcers and xerostomia. So all this can occur in oral cavity. So Kaposis sarcoma is a short note for you, remember well. So if you get a short note on Kaposis sarcoma, you must write everything about ENT manifestations in HIV. So in oral candidiasis, what happens? If you see the picture, the patient will come with this, like this picture. So they can come with other disease also. But then if the patient comes with so much oral leukoplakias, plaques, and so then you should think about HIV also. So it is the most common oral manifestations of HIV. It presents with tender white pseudo-membranous lesion. See, if there is a pseudo-membranous lesion, so then it is removable. So they may have removable white plaques. Erythematous lesions, they are red fibril plaques. So angular cheilitis, that is fissures at the side of the mouth, usually due to candida. Then candidial esophagitis is also seen in oral manifestations. That is, from the oral, it extends till esophagus, leads to serious inflammation of the esophagus. So this is very important. So the treatment, what contains is antifungals, what we give is cotrimazole, 10 milligram, 4 to 5 times in a day. Patients not responding to cotrimazole, fluconazole, 50 to 100 milligram orally, once a day for 3 to 7 days we give. Angular cheilitis is treated topically with ketoconazole cream and 2% twice a day. Candida esophagitis is treated with fluconazole 200 milligram OD for 10 to 14 days, and this patient who does not respond should be evaluated for other causes of esophagitis such as herpes simplex and cytomegalovirus. So many times HIV patients do have herpes simplex or a cytomegalovirus infection. So they are accompanied with these infections. So next is hairy leukoplakia. So this oral cavity lesion is almost seen exclusively in HIV patients. If you see like this picture, then you must always think about HIV. About half of the HIV infected patients with hairy leukoplakia develops AIDS in 16 months. So the pathogens are Epstein-Barr virus or papilloma virus. So the clinical features are they are vertically corrugated patches. See, corrugated patches on the lateral border of the tongue. The lesions may be flat or slightly raised. The vertical parallel lines have fine or thick hairy projections. See, you can see the thick projections vertically. So you will get typical picture when you then, if you get a patient like this, then you should think of HIV also if you get a hairy leukoplakia. Now next is herpes simplex stomatitis. See, you can see how these patients come with the stomatitis. See, you can see the gingivitis and peri-odontitis. See, you can see here in this picture. So vesicular and extremely painful lesions they may coalesce and form large ulcers of several centimeters. So angular cheilitis can also be seen. Gingivitis and peri-odontitis is seen. They are tender bleeding gums with What does peri-odontitis means? They have tender bleeding gums with erythema at the gum line. So the treatment is usually respond to professional dental cleaning and chlorhexidine rinses, or sometimes we need antifungal treatment also. So acute necrotizing ulcerative gingivitis and necrotizing stomatitis is very common in AIDS. So if you get such kind of patient, then you must think about AIDS. So they are present as red swollen gingival lesions that undergo necrosis and destruction of periodontal soft tissue. So the treatment is metronidazole 400 milligrams 3 times in a day for 5 days. So after ulcer, in general also you get this kind of patient. So these are very painful. So you can see the after ulcer on the lip. So these are very painful, and this is always almost most of the patient, if they come with this, then you must think about HIV also. So this, the treatment what we give is fluconazole topical application, that is 6 to 8 times in a day, or dexamethasone 0.5 milligram, what we call as betnazole tablet. So that is given, and 5 ml elixir, that is chlorhexidine 3 times in a day, that is mouthwash. So lidocaine 10% spray is advised, so because it is very painful also. So you have to give a spray. Thalidomide 50 milligram orally daily, increasing with 100 to 200 milligram per daily, at least for 5 to 7 days you can give. This tetragenic analgesic should be prescribed only to patients who are at the risk of procreation. The most common side effect is sedation and peripheral neuropathy. That is about the thalidomide. So you must be, when you are prescribing, you should be careful. So the next is salivary glands and larynx manifestation. So we have finished about ear, nose, oral cavity. Now we'll move on to salivary glands, larynx manifestation, and parotid. So the salivary glands, what are involved are parotitis, lymphoepithelial cysts of the parotid, xerostomia, diffuse parotid enlargement, Kaposis sarcoma, non-Hodgkin's lymphoma, laryngitis, fungal or viral, that is herpes simplex, cytomegalovirus, or they may be associated with tubercular disease, Kaposis sarcoma again. So Kaposis sarcoma can be in the ear, can be in the oral cavity, can be in the submandibular region, can be in the neck. So non-Hodgkin's lymphoma. So these are the what we see. These are the infection what we see in the neck and submandibular region. So the neck manifestations what we get is common neck masses in HIV, AIDS, that is HIV lymphadenopathy, maybe due to infections, neoplastic or parotid lesion. So cervical lymphadenopathy is very common in this, and palpable adenopathy is very common in HIV infection. It causes cervical lymphadenopathy, maybe due to infections or malignancy, that is neoplasms. So it may be associated with that. So the infection and malignancy which are associated are typical or atypical tuberculosis, histoplasmosis, toxoplasmosis, cat scratch disease. This is very important. That is because of Bartonella henseli infection. So cat scratch disease. Uncommon neoplasms are cutaneous uncommon neoplasms are Hodgkin's lymphoma. Cutaneous neoplasms are squamous cell carcinoma. So this may be associated with HIV patients. So the malignancies, routine malignancy, what we see with HIV is lymphoma, carcinoma, Kaposis sarcoma, and non-Hodgkin's lymphoma. So you can see the neck fullness, bilateral cervical node, lymphadenopathy, which is seen in Hodgkin's disease. So that is also associated with AIDS patient. So if you see Kaposis sarcoma, so this is the most common malignant lesions of AIDS. It can occur in any stage of HIV infection. So clinical features are multicentric, non-invasive neoplasm, respects the facial planes and involves the skin as well as the mucosa and the viscera. So remember well, so it involves all the plane. So this is multicentric, and the lesions appear as non-blanching, purplish and brownish papules or nodules. See, you can see in this, nodules are seen. So you must think about Kaposis sarcoma. So it is usually seen in oral cavity, tongue, gingiva, postpharyngeal wall, palatal papules, eyelids, conjunctiva, face, neck, upper neck, and towards. So all of the head and neck is involved by Kaposis sarcoma. So remember well, this is a short note asked. So what are the differential diagnoses? See, you can see the Kaposis sarcoma. See how it is seen. So the differential diagnoses are angioma, pyogenic granuloma. How will you diagnose? Only by biopsy of this lesion. So once you do the biopsy, what you get is, it shows excessive proliferation of spindle cells of vascular origin, endothelial cells, and extravasation of red blood cells, and hemosiderin-laden macrophages. So this is a clinical picture, means a histopathological picture, what you get in biopsy. So if you do a biopsy, that will give you the proper clue for HIV. So the treatment, again, here we give systemic chemotherapy, localized radiation, and intralesional vinblastine and cryotherapy. So this you can give. Vinblastine is a chemotherapy, remember well. So that is a anti-malignant drug. So that is given intralesionally, and cryosurgery is also done. So many of the patients who come to us with neck fullness, especially to ENT surgeons, you must always think of tuberculosis, non-Hodgkin's lymphoma associated with AIDS. So it is the second most common AIDS associated malignancy. So it is aggressive and late stage disease and occurs around 10 to 30% of AIDS patients. The types are nodal, extranodal, that is about 90%, and about 40% they are cyst, CNS lymphoma. So these are the types what you see. What happens about the CD4 count is in these patients, they fall below 200 cells per cubic microgram. So this is very important. So CD4 count always, if it is below and with neck fullness, then you must think about non-Hodgkin's lymphoma associated with AIDS. So the clinical features what you get is fever, night sweat, weight loss, non-tender, rapidly enlarging neck masses. What treatment what we give is especially chemotherapy and radiotherapy. So Hodgkin lymphoma, non-Hodgkin lymphoma is very sensitive to chemotherapy and radiotherapy. So lymphoepithelial cyst of parotid, this is also associated with HIV. So they are bilateral, multi-loculated, usually involves the tail of the parotid. So you can see here, bilateral. So if a patient comes, you must always think about, you must think about HIV. So clinical features, what we see is asymptomatic bilateral parotid swelling, reactive lymphocytes infiltrate parotid tissue, salivary flow, amylase are normal. So the treatment what we give, see when you write this, if only short note is asked about lymphoepithelial cyst or non-Hodgkin's lymphoma, please write all the signs and symptoms what you get in this parotid or acute parotitis or inacute parotid swelling, and the investigation additional, add with that CD4 count. So what treatment we do is, we do a parotidotomy, that is surgery. Second is intralesional tetracycline sclerosis or low dose of radiation have been tried in this case. So next, so this is the last slide, second last slide. In fact, what I have put is the clinical manifestations of AIDS. So they are always associated with opportunistic infections also. So immunologically, if you see low white blood cell count is less than 200 microgram. So this you have to be very carefully. That means it gives us a clue. See, that is CD4 count. So if it is less than 200 cells, then it is more vulnerable. So they may be added with opportunistic infections, lymphadenopathy, and patient may have fever, fatigue. Okay. So integumentary means what? That is poor wound healing, skin infections, night sweats. Respiratory symptoms, what they will have is cough and SOB. Gastrointestinal, again diarrhea, weight loss, nausea, vomiting. So with head and neck, they can come with gastrointestinal or CNS involvement also. Usually they are associated with opportunistic infections, that is protozoal infections, because of pneumocystis carinii, pneumonia, toxoplasmosis, that is encephalitis, and cryptorchidiosis. Fungal infections, of course, they always come with fungal infections, candidiasis, stomatitis, esophagitis, vaginal infection. Then bacterial infection added are microbacterium complex and tuberculosis. So remember well, when an HIV patient comes to you, maybe with a head and neck problem or with oral or ear problem, you must investigate for all these things, because that gives us a clue. Many times it becomes, it remains silent. Or when a patient comes with herpes simplex virus or with Ramsay syndrome, then you must think about HIV also. That is with infected with cytomegalovirus, varicella zoster virus. Then you must think. So the malignancies which are involved with HIV patients are Kaposis sarcoma. Already we have discussed all this. Non-Hodgkin's lymphoma, Hodgkin's lymphoma, invasive cervical carcinoma. So the AIDS dementia complex, what it is called, that is behavioral abnormalities may be seen, cognitive, motor diseases, or they may have CNS symptoms associated with confusion, dementia, headache, visual changes, personality changes, pain, seizure. That means AIDS clinically it involves whole of the body and whole of the system. So what is the take-home message? So this finishes our HIV in ENT manifestation. So the question they may give you is short note on HIV. See, now the question pattern is totally changed. I think you all are aware of it, because long answers are not there. So you may have total 20 MCQs and short notes. So the pattern is totally changed now. So out of 7, you have to write, maybe you have to write 6 short notes. So that will be the pattern now. Long answer questions have been removed. So you can have a question as HIV manifestation in ENT or a Kaposis sarcoma, maybe a short note. Kaposis sarcoma can be asked in surgery, any surgical field or in medicine also, because it involves everywhere. So the take-home message what for HIV is, India has the third highest number of people suffering with HIV in the world. ENT surgeons encounter a varied presentation of signs and symptoms. This is very important. So, ENT surgeons are more at risk. Not only ENT surgeons, all the surgeons. In fact, 2.1 million Indians, accounting for about 4 out of 10 people, are infected with the deadly virus in the Asia Pacific region, according to the UN report. High index of suspicion is necessary for specific presentations. There is a paradigm shift to quality of life. So universal precaution is must for every surgeon. So this is very important. Not only every surgeon or all health workers should be taken with proper precaution when you are handling HIV. So this finishes our lecture, today's lecture. Okay. Any questions to be asked?